Hello, all of you. Till now, we have seen the Ganesha sign during laparoscopic cholecystectomy, various landmarks like Rouvier sulcus, and anything whatever we are doing with the Kellogg's triangle, it should be superior or above from the level of Rouvier sulcus. Again, just to reinforce, this sulcus is known as Rouvier sulcus. Now, just for the learning purpose, especially for the postgraduates, there are so many unwanted situations that may arise, although not dangerous, but yes, it can increase the pulse rate of the operating surgeon, and few such situations we are going to discuss during intraoperative period in a patient of gallbladder stone disease undergoing laparoscopic cholecystectomy. Now in this video you can see the cystic duct clipped and cut, cystic artery clipped and cut. Now let's see what are the possible problems during intraoperative period that may arise and then how to manage it. Now this instrument is electro hook. You can see the tip of this instrument just like a hook, and there are basically two active parts with the help of which we can dissect the tissues. One is the tip of this electro hook and another one is the shoulder. For example, I am just pausing it for the purpose of description. Now here you can see, if I can focus it, this is the tip. Just focus on the cursor. This is the tip of the electro hook, and this bent portion, this is known as the shoulder of the electro hook. And why this information is important is during the study of electrocautery, it is related to surface area and how does it help a surgeon by knowing the mechanism of how the tip of the electro hook works and how the shoulder of the electro hook works. This will be discussed in another video lecture on electrocautery or energy sources. So let's go ahead. Till just for the purpose of knowing this instrument for undergraduates as well as postgraduates, just remember basically the two active parts, the tip of the electro hook and the shoulder of the electro hook. This white part is the insulated material in order to prevent inadvertent injury, so that we cannot accidentally touch the other associated, the nearby organs. You can see the gallbladder is being removed from the gallbladder bed. Presently the clips are in place, and very common condition, sometimes it may arise like this, small leakage of the gallbladder content. Can you see? Yes, very good. Good observation. Don't panic, just hold the gallbladder site from where it has come and continue your dissection. The gauze piece is already there. The lower side, just near the Kellogg's triangle. Just see how the traction is being given alternately, just to make the operating site where we are using electro hook taut. And this dissection is being done by pushing the tissue, and the pushing the tissue should be towards the gallbladder, not towards the liver, like this. This is going to help all of us who is involved in operating these type of patients to have a clear plane like this. So the take home message is, whenever required, you can use your mechanical force also along with electrical force. The electrical energy is being used during this use of electro hook. Now shoulder is working, the shoulder of the hook is working in between the mechanical push. Again the shoulder. In this way, the whole of the gallbladder dissection can be done. So this is a very good method. Very nicely gallbladder dissection is being done. Whenever required, shoulder is being used. Whenever required, the tip is being used, the electro hook. And now you can see the role of this insulated part at the distal most end of the electro hook. If suppose that is not there, then this electro hook will not properly work and will also burn a larger part of the gallbladder. Now, I was talking about what are the various problems that do occur during laparoscopic cholecystectomy. Till now, everything is fine. Let's see what happened next. Again, the pushing of the tissue towards the gallbladder. Almost half of the gallbladder dissected out of the gallbladder fossa. The uppermost instrument is known as atraumatic grasper, fenestrated, single joint atraumatic grasper. Now, alternatively, by changing the traction, you just visualize your field and then you work upon it like this. Just stay away from the liver tissue while taking the gallbladder from the gallbladder fossa. Now see, one complication is there waiting for you, right? And what is that? Displaced clip obstructing the cut end of the gallbladder. So what to do? Now what to do according to you? You just write your comment in the chat box. Think about it. Analyze the situation. Use your analytical mind. If suppose you are operating this patient, or even if you are not operating, you are a member of the team who is operating this patient, what will be the suggestion given by you? Write it down in the chat box. What to do at this level. Okay, let's see what has been done in this surgery. Okay, always the first important rule is always have an eye over any foreign body that is lying inside the peritoneal cavity, like this Liger clip, or what is the other foreign body that is lying inside this peritoneal cavity? Anybody? Yes, that gauze piece that is lying on the right side here. There's gauze piece and this clip. Now what we have done, we have just taken in the Maryland dissector, align the clip and just take it out through the 10 mm port, the epigastric port. This is a 10 mm port inserted through the epigastric area. So take home message, any freely falling body or any foreign body that is lying and not required inside the peritoneal cavity during the procedure should be taken out. Now see, this is clipped cystic artery, this is clipped cystic duct, this is duodenum, the gallbladder fossa very nicely dissected till now, and we are just holding the cut end of the gallbladder with an instrument. At this point, what we can do is either ask your assistant to hold this cut end of the gallbladder, or we can apply another clip if possible and continue our dissection. Let's see. Now in this surgery, what the team has decided is it's a non-fenestrated semi-traumatic grasper. They catch hold the cut end of the gallbladder like this. Gauze piece is still lying. And just continue your dissection if possible. Another important intraoperative minor complication that may arise is this. Again, the loose holding of the gallbladder curtain by the assistant. Now again, a problem in operating or a difficult procedure, but anyway, it's a team and we will have to support each other. So again, without pointing out the mistakes done by the assistant by loosely holding it, the surgeon again has asked the same assistant to hold on, and let's see what happens next. So these are the common, you can also see, and you must learn, this is fenestrated one, this instrument, this is fenestrated atraumatic grasper, and that one was non-fenestrated, the upper one. semi-traumatic grasper. This is electro hook. Now don't panic, just again set your position, traction, counter traction, and just continue your dissection. Although most of the learners must be having a question in his or her mind that what about the spillage? Whether it is justified? No, obviously it's not justified. Ideally we should avoid it. But yes, in any operative procedure there are three important things. The triangle is there, and on the three vertices there are three things. The first one is the patient, another one is the treating physician or the surgeon, and the third one is the machine interface, the technology, whatever we are using. And during interaction of human being and machine, sometimes it may happen and minor problems may arise. So we must be competent enough to manage these problems instead of having a complaining behavior till the patient is fine. So if the leaks are there, no problem, just wait. The gauze is still there and almost completed dissection, and we must take out the gallbladder first. As there is no empyema, nothing, the gallbladder almost not thickened, having a normal gallbladder wall thickness, so don't worry. But the question is still there. For this spillage, what to do? Think about it. Think about it. We'll come to this point. What should be done? Now the next important thing is, in most of the Western countries, now the gallbladder is out from the gallbladder bed, but it is mandatory in most of the countries outside India that this gallbladder bed, the gallbladder removed from the gallbladder bed, should be taken out from the peritoneal cavity in an endo bag. But the problem with our country is a huge population and most of the persons, they are not insured. So the cost factor is there. So in order to get over it, what we can do is we can use this gallbladder as a natural endo bag. Avoid spillage of stones and content while removing the gallbladder through the epigastric port. And even if something at microscopic level, you can very well always say that, sir, at the microscopic level there may be contamination of the epigastric port, but that can be taken care of by irrigation, copious irrigation. And here you can see the whole of the almost more than 60% of the gallbladder wall is inside that 10 mm port, and through that 10 mm port we have taken out the gallbladder. Port is still, this epigastric port is there, the port is lying outside, the gallbladder you can see, and this is falciform ligament, and here the suctioning of this gallbladder is being done, and finally this gallbladder will be taken out of the peritoneal cavity within few seconds from now, like this. You can see the various blood vessels in the right dome of diaphragm. This is liver, the right dome of diaphragm. Very frequently asked question, if there is liver abscess, the patient will present to us with higher right dome of diaphragm, or there is free gas under right dome of diaphragm in case of perforation. Now see, the gallbladder is out. Now what to be done for this spillage? Okay, we'll come to discuss this point very soon in the next part of this video. Till then, just think about it, what all we can do. Thank you.